We move to the next speaker, Professor Debabrata. I don't know if I'm going to say this. Okay.
I can introduce myself.
I can try.
Mukhopadhyay.
This.
Yes, thank you.
So, with your presentation, which is the role of pancreatic cancer derived exosomes, which, as you know, at least in the field of the exosomes, this is a very hot topic at this moment. So, please go ahead.
Okay, so let's make sure I'm working. No, which one is it for this?
I think that this is the laser point.
Okay.
And this is going up and down.
Okay, so I think the battery is kind of down. I don't know whether you can see it or not. You can see it. Okay. Anyway, I should move forward because time is essence here. Okay. And today, this is a nanotechnology, conference, nanotechnology platform. I'll talk today about a biological nanoparticles like exosomes, and how these, the exosomes can be used as a biomarker, and some of the applications in clinical practice. And technically speaking, the disease process I'm talking about is one of the real clinical challenge. The pancreatic cancer, as you know, is a really bad outcome in clinically. Only 5% patients survive after the detections after 6 months. So it's really bad. We need to do something. Now, I should thank, first of all my people. They're helping. And today, mostly at the end, I'll talk about nanotechnology a little bit, about what we can think about, where Michael Strano and Anand Jagota are helping us for developing this platform. So I'm from Mayo Clinic. As you might know, the Mayo is one of the clinical hub. We have 3 centers. This is the main center. I just moved 1 year ago from Rochester, cold place, to really warm Florida. And also in Arizona, we have another center. And the reason the move that we are now developing a translational nanomedicine center, and we believe it's a collaborative platform, bringing all the people throughout the world and ask them some fundamental questions, how we can move forward the nanomedicine in clinical practice. So this is the whole idea of the center development. We have, our lab is working for a long time with VHF. I'm originally from Boston, the VHF cloud. Dr. Folkman, Hal, Levorak, I'm from there. And eventually, after moving to Mayo Clinic several years ago, we just focus on pancreatic cancer as one of the theme, because technically there is no therapy. Okay, so all the clinicians really encourage me to move forward that directions. The biological part, we do a lot of targeted drug delivery, preclinical testing, clinical trial. Also, we develop a lot of PDX, patient-derived cell lines that eventually, hopefully get individualized therapy. And obviously, I'll tell about a little bit biomarker development in nanomedicine. Now, as I told you, the exosomes is my focus of this talk today. And interestingly, exosomes was discussed several decades ago. Dr. Wolf first time discussed about some of the particles coming from the cells, and he defined as a microvesicles. Technically speaking, this is nothing but a cell-cell communicator. We believe the exosomes nothing but cell-cell communicator, though it also secreted out a lot of garbage from the cells as well, same time. And so there are a lot of multiple ways. I don't need to describe everything that growth factor, hormones, cell-cell fusion, also adhesions. At the same time, exosomes is a kind of coming from one cells and hitting another cells. I'll give you an example how it really functions, particularly in the clinical practice. So theoretically, there are 3 kinds of the extracellular particle coming out. One is exosomes, microvesicles, and apoptotic body. I'll go through quickly that how we can define the 3 different things. As I told you, Dr. Wolf first time described in 1967, and then followed by several outstanding publications, the fragmented particles from the cell, which can carry several messages from the cell. This is the whole idea. And then can transfer from one to another cells, and give their communications. So also, the exosomes has a unique property called ectoenzyme activity. And the first time Trump's group described about that, and they define exosomes uniquely and isolated from the rest of the other particles. Now, I'd like to go quickly about the nano platform. I'll tell you that most of the exosomes around like more than like 50 to, originally this is a paper from Tram's, the cartoons we recreated actually, but exosomes can be 150 nanometer size. It's clearly a nanoparticle, which is coming from the cells. And I just give you another example, microvesicles, a little bigger than that, and also the apoptotic body, which is kind of 1 to 5 micron sections, and this is the cells you can imagine. So this is a fractionated form from the cells coming. And this is another cartoon actually to explain you, biologically, it's also different resources, and that's the uniqueness of these exosomes. Exosomes coming from the microvascular bodies, so basically taking up some of the small particle chunk in the cytoplasm and throughout to the system. Same time, the microvesicles actually coming out from the cellular membrane, so it has a lot of cellular signature in the particular membrane area. And this apoptotic body much bigger, it's mostly the dead part of the cells they're talking about. But still, there are a lot of questions, controversies there in this area. Now, it can, as I told you, that these particles can release from the particular cells and hitting several areas and changing the other cellular phenotype. Okay, so that's one of the issue is it can, when it's secreted from let's say cancer cells and can hit other cells, changing the mitosis, senescence, differentiation, angiogenesis, and so on and so on. So pretty much it carries some of the specific messages from the particular cell hitting distantly, like a hormone, think about, but it's a real particle, and change the phenotype. And I'll give you a couple of examples clinically how it functions, okay? Again, a little bit introductory of the exosomes, how to isolate, and there's some specific area where you can see that clearly some of the markers are very different than exosomes versus the microparticles, microvesicles, and the apoptotic body. So there are some specific markers for exosomes. And just keep in mind that when you are telling exosomes, it has a very specific marker. We are not talking about that other part. Now I can skip this slide for time's sake. So come back to the clinical question. So what we thought originally that, not only us, several other groups thought that exosomes coming out from the cells and might change the macroenvironment, not only microenvironment, the macroenvironment, that means it go beyond, the tumor, the stroma and others, and change the hematopoietic cells, maybe some of the other distant islet cells, particularly for pancreatic cancer, I'll tell you. And it can be a biomarker. So in understanding that, can we, since exosomes coming from the cells, carrying all the important messages, unique messages from the rest of the other exosomes, from the normal cells, so can we use as a biomarker? So this is the current field. I mean, a lot of laboratories working on this particular area, and I'll tell you something unique. So back to the basic questions again, clinical questions. I'm from Mayo Clinic. So when I moved from Boston, one thing everybody talking about, so you're from Boston, so you have to do something which is very clinical translational driven. So one of the challenge at the time, the pancreatic cancer early detections, and still no, actually, in fact, there is nothing there. And the patients are coming to the clinical practice in clinics, and within 6 months, their lifespan. So it's terrible. And Suresh Chari, one of my friends, is a clinician from Mayo Clinic, is GI doc. So he told me one thing. So one thing they realized, and they published a lot of paper, that the patients coming, they got the very high level of diabetes. They call early onset of diabetes at the age of 50. And after 6 months, they have a very aggressive pancreatic cancer. Now, one fundamental difference is the regular diabetes is usually when you're diabetic, we are actually gaining weight. But for pancreatic cancer diabetic, they're losing weight. So this is only a little bit fundamental difference. But think about millions of people are diabetic, and how many people got pancreatic cancer. So that's a major challenge for a biomarker as early diabetic. So we don't know what to do, right? So that's the question. Now, when I moved to Mayo, so one thing is very clear at the time, that 85% patients, so this is Suresh's work, 85% of pancreatic cancer patients has a fasting glucose level 8 times much more than regular, and eventually they got pancreatic cancer. And secondly, that that based on this particular observation, NCI putting a big program right now, as we speak, that how we can differentiate what is the real cause for diabetes, why pancreatic cancer patients have such an onset of diabetes, such a high level of sugar, blood sugar level, what the real mechanism. Secondly, can we use as a biomarker? But major challenge is to doing that the onset of diabetes is a paraneoplastic phenomenon because it caused due to the cancer. So that is a fundamental difference. So now, American Association of Diabetics, they call type 3 diabetes, particularly this phenomenon, okay? Type 3 diabetes. It's a very different kind. And I cannot talk another session maybe what is the basic difference. But what is the major challenge? So the major challenge of this, that how we can differentiate the diabetic patient, regular diabetic patient with a pancreatic cancer-induced diabetes, right? What is the other way to do? So I'll show you something, maybe that's the directions we are moving forward. So when we talked to Suresh and we follow up this paper, we did one experiment with Suresh that adrenomedulin, which is in the high level in the patient plasma, actually cause as a beta cells resistance. And we published this paper already. So adrenomedulin is one of the factors that we found in some of the blood samples. So the problem is, when we did the mechanism, that is perplexed. We perplexed completely because we didn't see that much adrenomedulin in the serum. And serum, if you put serum itself, it's okay, but if you isolate adrenomedulin from there, it didn't function. So what's going on? There is a big misconnection between these two together. So make a long story short, what we did actually in that follow-up paper, that when we isolate the exosomes from the patient samples and did the similar experiment, we saw clearly that the insulin resistance from the islet cells. So, and Maury Cork is one of the top, pancreatic cancer, investigator. Commented is called exosomopathy. This is very nice, thing. So you put it. But come back to the point. So what you're talking about, the pancreatic cancer derived exosomes coming out and close by all the real, normal islet cells, and that go there with adrenomedulin, maybe one of them, maybe multiple other factors there, and converted those islet cells as a drug in insulin resistance. And that's why this is one of the models we are proposing right now. And pretty much all the other people, produce this result. But still the questions that are coming back to the question. So this is one of the examples. So when you do the nanotracker, you see that clearly a huge amount of one spike of exosomes coming from the plasma of the panc patients, around 109 nanometer size, like a nanoparticle, exactly, which is in adrenomedulin presence as well as TSG101 presence. And we saw the same phenomenon for lipolysis process. So give another clinical problem that when patients are coming in the pancreatic cancer, they lost, initially the fat loss happened. Then the muscle loss. Cachexia is one of the major problems. The patient die, actually, technically speaking, due to cachexia, by the way. And I'm not a clinician. I learned these things after joining Mayo. Look, major problem metastasis is actually that cachexia is a real follow-up. That's the major problem. Now, one thing is important, that TNF-alpha, which is one of the classical cachexic, or rather lipolysis factor, when they use a clinical trial, they couldn't see any effect in cachexia. So anti-clinical trial antibody didn't do anything with weight loss. But one of our hypotheses may be, the TNF-alpha actually carrying or adrenomedulin carrying by the exosomes and hitting to the adipose tissue nearby, and then converted to the lipolysis. So this is the hypothesis right now. So this is all I'm talking about, some basic science, and maybe clinical questions will come. Now, come back to quickly summarize the whole thing, that exosomes, from patients actually can carry adrenomedulin plus other lipolysis factor that can cause, early fat loss. So I didn't show you that we have now another paper is coming soon, that clearly there is a basic difference between pancreatic cancer patients between fat loss, fat versus SAD. Fat means visceral fat versus, sub-Q fat. So there's a very fundamental difference even in fat loss. So we are going that directions. That can be helpful for biomarker development as well. Now come back to the question, again, we also working that whether, exosomes can use as a targeted, drug resistance part. I'll not talk today. I'll go back to the basic biomarker part again. That's my interest. Now, one question is there. I mean, a lot of laboratory, you can see a lot of papers coming out in Nature and top journals that they're thinking that exosomes can be used as a biomarker. Obviously, it's correct because they're carrying all the signature from the tumor, right? The major problem is when we get exosomes, think about considering tumor heterogeneity. So exosomes also very much heterogeneous, right? I mean, it is all over the places. So how do you know that which is particularly from cancer-driven exosomes? That is one of the challenge in this field. And secondly, if you collect plasma samples from patients, actually not more than 20 to 30%, so maybe less than that, actually 15 to 20%, based on the disease steps, are coming from the tumor samples. So that is the major challenge. So there are two questions. Whether we are collecting exosomes is from tumor cells, and if it is true, what kind of heterogeneous population? So that's a real, perplexed in our field, and that's one of the areas we are working on it at a heterogeneity and identification part, and also protein identifications. What kind of protein you should isolate? What kind of protein you should see? CA19-9 classically for pancreatic cancer detection is clinically approved. But the interesting thing is, when you check the CA19-9, the amount of CA19-9 exosomes is so low, you can see it clearly, but very, very low. Sometimes there is no regular, ELISA system can detect. We can, but like 40 or 30, there's a number versus 3,000 number in the plasma. So those are the detection limit is another important issue we are challenging right now. So that's why now the nanotechnology coming back. So what we are doing right now, we're collaborating with the Michael Strano's group in MIT, as well as Ann Jagada's group in Lehigh University. So we are joining together and to solve this puzzle. Because we are using a SWNT-based nano platform where Michael already and we published together several papers using a detection system for nitric oxide, hydrogen peroxide, glucose. Now we are developing a same platform for protein level, very specific, very, very femtomolar of protein we can detect from the exosome. So this is the major current thing going on, a prototype where you can monitor biological content of exosomes. There is another word I just deleted called biological content of single exosomes. I'm a little bit nervous to put single. It is a real challenge. And Michael's group and our group are working last 3-4 years just to solve this puzzle. How we can detect each protein from single exosomes. So that's one of the things we are doing right now. I hope we can show you next year something new. And same thing, we develop algorithm. Think about heterogeneity, right? Now we know pancreatic cancer is divided by 4 classical groups, not one group, 4 different groups. And we also part of the international consortium, pancreatic cancer divided into 4 groups. So it's more complex area we are working, so we need to think about the heterogeneity part. And also some groups are working drug delivery method. So exosomes can be used as a drug delivery system, but there are a lot of challenges. One of the major challenges is targeted drug delivery. How we can convert patient exosomes to alter their receptor or whatever, and then hitting to the particular tumor. So this is another area we are slowly developing some of the area. And I think, obviously I should stop right now because I can see time is slowly running out. And thanks to all the agencies supporting us. And thanks to you guys just for holding, 20 minutes without discussion. So please, I'd like to throw some questions. I'd like to answer as many as I can.
Thank you very much.
Yes.
Joy.
Thank you so much for your talk. I was wondering, at what time in the tumor development do you think that they start excreting these exosomes?
This is a brilliant question. For pancreatic cancer, think about, for pancreatic cancer is a very early disseminations. So what does it mean? That means when we see patient coming in the clinics, 6 months ago, when you do CT, same patients, nothing there, 0. We cannot, by CT cannot detect at least. But after 6 months, it's all over the places. So that means there is a very early dissemination going on. Now, one thing we know that the KRAS mutation, which is one of the leading cause, 90% time, we can see clearly the KRAS is in the signature, mutation signature, inside the exosomes. So can we detect a type 2 diabetic patients very early stage of their disease, or I should say that before they come into the clinics. A simple system, get the KRAS mutations in the very early stage. That is the challenge we are taking. But they do disseminate. They already metastasize much earlier within bigger tumor inside the pancreas.
Thank you.
Okay, wonderful. Yes.
So there is some hypothesis that exosomes also could manipulate the T cells to maybe have a different response to cancer. Is there any evidence, like in your case, that it could exhaust the T cells also somehow?
Absolutely. So this paper is in revision stage right now. We saw that not only T cells, that exosomes from patients manipulate the dendritic cells, and now they convert it to MDSC cells, and they are highly tumorigenic cells infiltrating inside the tumor. So exosomes coming by early stage, and they start manipulating the whole immune system, converting them a different aggressive, Th2 class maybe, and get inside the tumor. So you are absolutely correct. So this is one of the challenge. We can see that. Okay. Yes.
Thank you for your nice talk. A few years ago, it has been published that the glypican-1 protein on the exosome from the pancreatic cancer cells can be used for the good diagnostic tools.
So glypican.
Yeah, glypican-1
Okay.
is published. And do you have any different targets?
Well, a great question. The Raghu Kaluri is a great friend of mine, actually. We worked in Boston together. So that paper in Nature that you're talking about,
Yes.
What he did at the glypican as a target and pull down and so the exosomes. The problem is, in that approach, that glypican, you might know that is TGF receptor beta 3. It's like TGF beta receptor 3, actually, glypican, like endoglin, same kind of structure. And it does express a lot of other cells, endothelial cells and other cells. And we published a molecular cell paper long time ago when I was in Boston. Glypican also using in angiogenesis, and blah, blah, blah. I didn't go that direction. So his method is very nice. We never tried in Mayo Clinic. We tried, but didn't work. We didn't really establish that method. But we got a very new protein I cannot tell right now, and which is, we believe it is unique. But again, it's not unique for pancreatic cancer. I don't think there is any protein just specific for pancreatic cancer expressing exosomes. We didn't see. We did a lot of proteomics, everything. We can see same thing for other area. So what we are thinking, let's take glypican, and then validate with other marker. So, but we have a little better, another marker than glypicans, and hopefully we'll see what happens. But very good point. But your work is very good also.
Sorry?
You presented yesterday.
Yes.
Yes, very nice.
I'm also working on the exosome
I know.
field, so that's why I'm asking.
I know. Thank you.